Yes, Mariner was designed to fill an unmet medical need. We now have data to suggest that the majority of venous thromboembolic events in the medically ill population globally are occurring in the post-hospital discharge period. So therefore, Mariner was designed to address the question, is there a need for extended thromboprophylaxis with a direct oral anticoagulant for these patient populations, especially if we select an appropriate at-risk medically ill population. So it's an acceptable benefit-risk profile. Yeah, so Mariner had some, I would consider, very bold and quite innovative design features. So it was the first trial of extended thromboprophylaxis that randomized patients at hospital discharge. Because as I said, this, in our view, represented the greatest unmet medical need in this population. Previous trials had randomized patients during the admission period. It also treated patients for slightly longer than previous studies at 45 days. So patients were randomized at hospital discharge to receive either rivaroxaban or placebo for a 45-day period. Because again, data showed that the majority of these venous thromboembolic events occurred within this 45 to 50-day window after index hospitalization. It was also one of the few trials to use a dose reduction strategy in a fragile population, namely patients with renal insufficiency, to improve safety profile of the oral anticoagulant. It was also the first trial of extended thromboprophylaxis to use a validated VT risk scoring instrument, namely the improved VT risk score, to select, identify, and enrich the population for venous thromboembolic events. And also we used an added biomarker, an elevated D-dimer, to do the same thing as well. So these represented, I think, very interesting and innovative design concepts. And then lastly, from an endpoint point of view, it was the first study in over 22 years of extended thromboprophylaxis to have mortality as a key endpoint. And that was quite bold. Well, what we found in Mariner is that we missed our primary efficacy endpoint using symptomatic venous thrombosis and venous thrombosis-related death as the composite endpoint. So it was 1.1 versus 0.83% with the placebo versus rivaroxaban treated patient groups, and this difference was not statistically significant. It was represented a 24% relative risk reduction or an 0.27% absolute risk reduction. Again, these differences were not statistically significant. Now, what we did see in Mariner was looking at the pre-specified secondary outcomes that, again, should be considered exploratory because we missed our primary efficacy outcome. We saw a significant 56% reduction in symptomatic venous thrombosis, and if we had used all-cause mortality as our mortality endpoint as opposed to VT-related mortality, we saw a significant 27% reduction in the combination of symptomatic venous thrombosis and all-cause mortality. And I think these have important clinical implications as well. What we also saw in Mariner is that we indeed improved our safety profile for rivaroxaban using some of these, again, dose reduction strategies as well as some key exclusionary criteria. So in a safety population of nearly 12,000 patients, we had 17 major bleeds in the rivaroxaban group, representing an incidence of 0.28% versus 9 bleeds in the placebo group, representing an incidence of 0.15%. So no statistically significant differences in both groups. We had 3 critical site bleeds in rivaroxaban versus 2 in the placebo group, and 2 fatal bleeds in the rivaroxaban versus none in the placebo group. So an excellent safety profile. Now, of course, there was an increase, and this increase was statistically significant, of non-major clinically relevant bleeding in the rivaroxaban versus placebo groups, about 1.42 versus 0.85%. But again, one would expect this with comparing an anticoagulant versus placebo strategy. So in essence, even though we missed our primary efficacy outcome, what we learned from Mariner is that using an appropriately selected patient population, we can likely reduce the burden of symptomatic venous thrombosis by over 50% in these appropriately selected patients at the cost of very little to no major bleeding. And I think that was the key message that we learned from Mariner. I don't think so. I think the Mariner results are specific to rivaroxaban because we learned from the previous parent trial of Mariner, which was Magellan, that the 10 milligram dose of rivaroxaban was effective in this patient population. So Magellan was the only one of the DOAC trials in extended thromboprophylaxis that met both of its primary endpoints. None of the other DOAC trials did. Where Magellan failed was in the safety side of the story. So it incurred anywhere from a 2 to almost 3-fold increased risk of major bleeding. And I think each of the benefit risk profiles are very DOAC specific and should be tailored for the individual DOAC. So what we did, I think, in Mariner is really improve the safety profile of rivaroxaban using these key exclusionary criteria, as well as I think now have further evidence to show that the 10 milligram dose of rivaroxaban is quite effective in this population in reducing not just total VTE driven by asymptomatic ultrasonographic disease, but also symptomatic venous thrombosis as well. What's important to us is what we found in Mariner is that the dose reduction strategy that we attempted in patients with renal moderate renal insufficiency was not successful. Though we saw a good safety profile, we saw absolutely no evidence of efficacy of the reduced dose of rivaroxaban, 7.5 milligram, in this patient population. So likely that dose of rivaroxaban from a thromboprophylactic point of view should not go forward. So what we will do is further analysis in the 10 milligram dose population, which constituted about 82% of the Mariner population. So when we looked at those results, they were actually, I think, much more compelling than the overall study results because we did see now significance, not just symptomatic VTE, symptomatic VTE and all-cause mortality, but a statistically significant difference in what I call major and fatal thrombotic events, including symptomatic VTE, myocardial infarction, non-hemorrhagic stroke, and cardiovascular death, again on the rivaroxaban side versus placebo side. So I think this represents an important secondary analysis, and we have other important analyses as well, as looking at the Magellan study, removing those patients at high bleeding risk as defined by Mariner, and looking anew at this Magellan Mariner population to see, okay, can we select a high enough risk patient profile from a venous thrombosis perspective with a very safe extended strategy as we saw in Mariner.